Uh, Very good evening and namaste to everybody. First of all, I'd like to congratulate Mechi Eye Hospital, Dr. Puru, the chairman of the hospital, and Foundation Eye Care. I think they are going to celebrate their 27th year tomorrow, so congratulations and thank you for having us here. Now today, I would like to talk and give you a bit of a storytelling about eye care in Nepal, mostly on my own personal experience and from the time that I started. And this is going to be very, very personal. If you look at the 5 decades of eye care in Nepal, the decade 1980 to 1990, you can see that we focused on the National Blindness Survey and infrastructure and human resources training. And I'm very lucky I was part of the National Blindness Survey as a very young medical officer and visited more than 15 sites all over Nepal as part of the blindness survey. The second decade is from 1991 to 2000, where we further looked into quality service and technology besides the two. Then, in the next decade, we started looking at the service coverage, which is very important, sustainability, technology, in addition to what we were looking for. And 2011 to 2020, you can see that we all started getting up into the needs of subspecialty services and trainings, of course. Research and documentation, monitoring and evaluation, sustainability and management was very important as the process came on. And then breaking barriers. And finally, in the last decade, the subspecialty continued, innovation and technology, scaling up the services, and breaking boundaries. We started moving out of Nepal, and sustainability, research, of course. Yeah. Now the 1980-81 survey, which was conducted, is still considered as one of the best national survey ever done anywhere. Very scientific, and according to that survey, the blindness prevalence was about 0.84, and almost 80% of the blindness was found to be avoidable, either curative or preventable. And cataract and sequelae consisted of 83.6% of the avoidable blindness. And when I said sequelae, it's the complications after surgery. Trachoma was very prevalent. You can see the blindness because of trachoma was about 6.5%. And again, the distribution of blindness was very interesting. It showed that the western Tarai of Nepal was endemic in trachoma, and then Madhya Pradesh had very high prevalence of cataract and high prevalence following cataract surgery. At that time, the population of Nepal was about 15 million when the survey was conducted in 1980-81. Now, this is how we used to do surgery. Intracapsular extraction, 180-degree Graffy's knife section, removal of the lens with either cryo, forceps, or tumble, or erisific. And, I personally feel that I have very strong legs and back because of standing like that for many hours. And you can see how the surgery was with very little precision. And the sutures that were used were 8/0 virgin silk. And many a times we used to see very inflamed conjunctiva because of the knots of these sutures. And then, of course, the FAK glasses. And then Nepal moved into the era of standalone eye hospital. And Nepal Eye Hospital, which is parent hospital to most of us, was the first eye hospital in Nepal. And the concept of the eye hospital was basically autonomous and looks mostly into cataract surgery and refractive error. And it is community-based. There's a pricing tier and cost recovery, sustainability concept, quality assurance, and good governance. And the idea was to stay outside the government. Now, at that time, the barriers that we faced were because of the lack of human resources, infrastructure, consumables and equipments. And most of the equipments were very expensive, and training and research. And this is some kind of microscope that we used to use, modify the laboratory microscope, and then use in the field with a side light, and rotate the eyeball to see whether we can see any ray reflex for the remaining cortex to be removed. And these are portable microscopes that we later moved on to. Anyway, our mission at that time was an initiative to provide sufficient in terms of numbers, in terms of quality, good quality. Quality was always our main mantra, and sustainability. Modern eye care in the community. And so we went on to adapt the surgical techniques and make sure that it is simplified enough and test it. And once standard operating procedures were produced, it was used for global training. The small incision surgery and cataract surgery, the surgical technique was standardized, gave extremely good results. We wrote SOPs, and training started here and also globally. This is just a picture gallery of a small incision cataract surgery. And then we had to prove to the world that small incision cataract surgery is safe and good results, and it can produce good long-term results. So we had to do a clinical trial here in Nepal. And this was a clinical trial done with Dr. David Chang. And we found that consistently over 1 year, the visual results, visual outcomes were comparable between the two techniques. And this was later published in the Cataract and Refractive Surgery Journal. So, now, of course, cataract surgery is very straightforward, predictable, quality assured. But in community, when we talk about community cataract surgery, it's still a challenge. These type of cataracts that you come across, complex cataracts with capsular changes, nucleus, jonules, pseudoexfoliations, corneal scars, many other things that you come across. So, the thing that we were best in Nepal was to address the whole cycle of cataract surgical delivery. This is where Nepal really excelled for quality assurance, team building, station-wise, screening and diagnosis, governance, and partnership. All these components were addressed to look into the community cataract surgery. And this is often now scaled up in other countries, many other countries where they have benefited when we talk about the cataract surgical delivery in a more comprehensive way. This is just a box to indicate the human resources in Nepal. In 1998, we were 55. I think we are about 540. When President Saab? About 540? Yeah. So, optometrists, you can see that the numbers very good. Ophthalmic assistant, the number is very good. But we have started addressing another important manpower, which is biomedical engineer. The causes of blindness in 1980-81 and causes of blindness now are quite different. The prevalence of blindness since 2011 has come down from 0.84 to 0.35%, almost less than half. Nepal stands out as one of the few countries to be able to do this. And in 2000, we were addressing all cataract patients with IOLs, which stood out against many of the surgical ways that our neighboring countries were doing it. So we were much ahead in providing all intraocular lenses. The residency program, I must say that the Institute of Medicine under Professor Madan Upadhyay had pioneered. Now, of course, Kathmandu University and National Academy of Medical Sciences and many other institutions provide residency program. iBank and IOL manufacture from Tilganga Institute of Ophthalmology. Trachoma was eradicated with the effort of NNJS, which is a great thing that we don't have trachoma now. And if you look at the cataract surgical rate from 1995 to the last data that I got was 2019, was almost 8 times or more than 8 times. And now, of course, we're talking about using phaco in the community. And we're discussing about the cost of the machines and consumables, and they're all coming down. Intensive standardized training programs, backup VR team, user-friendly machines, large target group, selection of cases, ways to lower the consumable costs. Yeah. Now, this is one PowerPoint that I really wanted to emphasize. Some of the unique things it was a national initiative. I must say it was a national initiative. It was based on a scientific survey of 1980-81, and there was tremendous collaboration between large stakeholders. And it was professional. This is a nice way of saying apolitical, but it was professional. Team structure, quality assurance and sustainability. Each ophthalmologist, when they wanted to set up an eye center, they will think about quality assurance and sustainability already now. And I think it's important now that we talk about public, private, and public and private partnerships. I think we have to move into that direction. This morning, when I was coming to Japa, I was visiting the Golcha Eye Hospital, and I was told by one of the Golcha families that the Golcha Eye Hospital was one of the first eye hospitals outside Kathmandu. And after Golcha, Lahan came up. He said that Mr. Ramlal Golcha, 40 years ago, when he developed cataract, he traveled all the way to Calcutta to get his cataracts done. So when he was coming back, he started thinking, why not we can have cataract surgery in Nepal? So this was, when he came back, he established the hospital to make sure that others get cataract surgery. Now, of course, of all these years, we have been having reverse exodus of patients from the other side of the border. And this is because of all the hard work that everybody has put together. Now, today, I'd like to talk about phaco and SICS. Nepal is one of the few countries in the world where many surgeons have both very good expertise on SICS and phaco. And there's a great need globally. I thought, why not we call this type of surgeons as hybrid surgeons? So, let's start calling it hybrid surgeons. I think a lot of people will start calling it hybrid surgeons now. And now I really like to recognize the contributions of Dr. Pokhrel, Dr. Nicole Grasset. Many of you may not know Dr. Nicole Grasset. Dr. Nicole Grasset was a French epidemiologist and public health personnel who eradicated the last case of smallpox from India. And after she finished her work there, she came to Nepal to help with the blindness program. And she was really behind the survey. She also helped to put together a lot of the NGOs together from many other countries to come and work in Nepal. And I definitely have very fond memories about this lady. And she, later on, she came with her dog all the way from Switzerland to have her cataracts done in Nepal. Such was the faith she had for Nepal. And many more of my seniors, my contemporaries, and all these young people that I hear, each of you have put in some effort to make this program of what we have now, what we can boast around the world. And it has been, and it is still going to be a collective effort from everybody. So let's all work together. Thank you very much.